Hi everyone, it's Melissa from AIM. Let me just get this microphone on, it keeps falling off. I was coming here tonight to talk about interpreting your path report. So I hope you guys are all having a wonderful night. I am going to try very hard to, I had printed one of my family members' pathology reports so that way I could try to show you at least just visually where you would find some of these things on a path report. We're not going to focus on this. It's just mainly so that you can see where they are. The main focus of tonight is to kind of show you what are the things that you need to know from a pathology report that would be helpful to interpreting kind of what the heck does all this stuff mean? What are the things that are important? What things can you actually just avoid looking at because they're not so important? And then we'll talk a little bit about each of those sections to try to give you a better understanding of kind of what this paper means. So essentially when you first get your pathology report and you look at it, now obviously, you know, the company's name will be up here and we're just kind of going to ignore that for now. And then what you'll see is, and I don't know how well this will focus, but over here, there's something called a path report number. That's also called an accession number. That's basically how the pathology department identifies you. It's like a barcode, but in words. Hi, Polly and Amber. So essentially, every pathology report has some type of path number or accession number. It's how they categorize and kind of catalog everyone's tissue. You'll also see at the top, which is blacked out, all the patient information, and that would be you, the date that things were removed. And then the first thing that you kind of see here, and let me see if I can, my hand because I'm backwards, is clinical data. So when you look at clinical data, what's going to be under there, it's not really about your mole from a pathology standpoint. What you're going to see there is like the physician's description of what the mole looked like clinically when you're in the office and it's being examined. So words that you might see there would be like papular, which means that you can feel it sticks up. Macular, which means it's flat. It might give a description of how big the mole is or the thing that is being removed. It might talk a little bit about whether or not it was bleeding, if there's a scab on it. It might say that it's, if there's redness around it. Those types of things are what would be found in the clinical history. This is not a diagnostic diagnosis. It basically is just the doctor's description. So some things that you might also see in that clinical section is like it might be melanoma versus atypical mole or melanoma versus basal cell. That doesn't mean that you have those things. It just, that clinical data is how the physician communicates with the pathologist to give them a better understanding of what it looked like clinically. So that's that section. And then typically what you'll see next is a diagnostic summary or a diagnosis. And that's actually the true diagnosis, or what the pathologist feels is the actual finding. So that's under this diagnostic summary. It's sometimes called diagnosis. Essentially, that's where the bulk of the useful information will be. Under this section, you will find, if, let's say for our intensive purposes here tonight, it is a melanoma. So under that section, the things that you'll find are, one, it's melanoma, what the histotype is. So that means, is it a superficial spreading melanoma, which is the most common type? It's like 70% of people that have melanoma have superficial spreading. Is it nodular? Is it acrolentigenous? Is it lentigo-maligna? Is it a Spitz nevus? That's where you'll find that information. So histotype. It'll tell you a depth of the melanoma. So if it's melanoma in situ, it's going to say melanoma in situ. If it has any type of invasion into the skin, that's called a Breslow depth, and that's where you'll find that information. It's reported in millimeters. So invasion could be 1/100th of a millimeter, 0.01, or it could be 27, that's unlikely, or 4, 1.3, or 2.6. So that is an actual measurement of how big your melanoma is from the top of the skin to how far it extends down into the skin. It's actually one of the most important things that we need to know when we look at your path report, because that's partially how we stage. It's one of the most important things, especially in the initial staging, between stage 1 and stage 2 especially. So a Breslow depth will be found typically in this section. You'll also find pertinent positive information. And when I say positive, it doesn't mean that it's a good thing. It's just pertinent positives, essentially anything that is present in your pathology that is worth reporting. So those things would be like ulceration, which means does the top of the skin lesion have like what looks like a brush burn where the skin is actually eroding away. And that typically happens in moles that either grew into melanoma very quickly or if they ran out of blood supply. Sometimes people get really worried because sometimes they'll pick moles and are concerned that that will show up as falsely ulcerative. But you can actually tell the difference pathologically between ulceration and trauma, which would be the pickers. So that's something that would be reported there if there is or is not ulceration. It'll say ulcerated or non-ulcerated. You'll also look for things like margins. So they'll oftentimes report, if margins are positive in this section or if they're negative. They'll report whether there are things like invasion into the local lymphatics or invasion into what's called the perineural space, which are the nerves that kind of innervate the skin there. Another thing that they will often report in this diagnosis summary is something called TILs, which are tumor infiltrating lymphocytes. And the reason that those are important is that they actually are your immune system. So the way that this is reported is brisk, non-brisk. Sometimes you'll see absent. And the reason that we need to know this is that in folks that have absent TILs, that's actually a pretty poor prognostic factor because that means that your immune system isn't recognizing that the melanoma is there. Actually having a brisk tumor infiltrating lymphocyte response is a good thing. It has a better prognosis. So those are all sort of the characteristics that you will see in the diagnosis section. And then the next part that is oftentimes on here, and it usually is separated in some way. In this particular pathology report, it's separated by a line. And so the next thing that you'll see is actually more of the pathology department's description. So you'll see a gross description, which is essentially what the path specimen looked like when it came in the container. So a lot of times this will just say, this piece of skin was brown to dark brown. It measured, 18 by 12 by 3 millimeters. There was an inked line around it because a lot of times when physicians remove moles, they actually draw a picture of what they want to follow so that they can cut it out appropriately. And they'll say in how many sections it's submitted. Sometimes pathology gets submitted in multiple pieces. Excuse me. Trying to catch a cold. Sometimes it'll get submitted in several pieces. Sometimes it'll get submitted, just in one piece. But that's where the pathologist will describe, what it looks like in the jar. And then what happens next is something called a microscopic description. The microscopic description is actually what the melanoma looks under the microscope. So it's a physical description of what the cells actually look like at a microscopic level. Now, a lot of times, and especially, both in my clinical setting, but also in my position here with AIM, I get a lot of questions about things that are reported in this microscopic section. The reason it's tough is that it has to be on there because the way that you can think of this microscopic section is the pathologist's justification or definition of this is melanoma. So it's like there's supporting evidence behind saying that the final diagnosis is melanoma. A lot of times this section will actually be very similar across pathology reports because when you describe cells under a microscope, melanoma has a very specific appearance under a microscope. There are certain things like, scattered mitoses and nests of cells and growth along the junction, just to name a few confusing things. But there are a lot of changes that you see pathologically that are definitive of melanoma. And those are the things that the pathologist is actually looking for. So a lot of times this microscopic description will be the same or very similar across multiple pathology reports. Things that they'll report here are things like that there are melanocytes present. Well, okay, that's what melanomas are made of, are melanocytes. They're what give your skin their pigment. So it's expected to see melanocytes. It's expected to see nests. It's expected to sometimes see pagetoid spread. Pagetoid spread is really a migration of melanocytes up into the epidermis, and you see that quite a lot with melanoma. There are also places where they may hear about regression, and what regression really is where the immune system starts to attack the melanoma, and it actually you see the melanocytes actually break out of that, and what's left behind is sort of like a scar. And so when you see regression on a pathology report, and that would also be reported in the diagnostic summary, but when you see regression, it sometimes means that the Breslow depth is a little bit larger than what can actually be measured, because the assumption is that area that is regressed it used to be there and it's just now gone. And so by and large, the microscopic section, if you have questions about it, if you do read it, really those things should be addressed by a medical professional. You're not going to read the microscopic section of your pathology report and probably understand it, and that's okay, because you're not supposed to. And if there are questions that you have about things in there, you should ask me, ask your doctor, because really that is something that needs explained by a medical professional if you do have questions about that. So after those two sections, what it looks like on a global level from the outside, and then what it looks like from a microscopic level, then a lot of times bigger centers, bigger university hospitals, bigger pathology departments will put in there what's called a synoptic, and it's basically what it says in the diagnosis, but in a more cohesive manner. So it'll be like Breslow depth and give a depth, ulceration, present or absent, mitoses, and it'll either list that there are mitoses or no mitoses. It'll say TILs, brisk, non-brisk, sparse, absent, regression, present or absent, perineural invasion, so that's invasion into the nerve, remember, present or absent, lymphovascular invasion, present or absent. So it's more of like a chart that makes reading a pathology report a heck of a lot easier, not only for patients, but also for us. So sometimes you may see a synoptic, which is basically a very organized summary of what the pathology report looks like. One thing that I did also want to mention, because this might be present on your pathology report, is something called satellites. Satellites also are a poor prognostic finding if you find them in your original pathology specimen. The reason is that they're local metastases. By definition, a satellite should be between 0.05 of a millimeter to 2 centimeters from where the primary lesion is. And just to give you an idea of where that is, if this big dot right here in the middle is my melanoma, and this eyeball looking thing is where the pathologist took a sample out, this would be a satellite, that would be a satellite, and then this borders on something called in transit disease. So that would be far enough from the primary that it would no longer be a satellite, but be more of an in transit or in between metastasis. Something over here would also be an in transit metastasis. So in transit or local recurrences versus satellites really have to do with the distance between where the melanoma is and where they see skipped melanoma cells. So I just wanted to mention that, because there will sometimes, if those are present, that will be reported in that area too. So, in summary, what is important on a pathology report? always look at the final diagnosis. That's where most of your information is going to be found. So you're looking for Breslow depth, and that's, again, the measurement of the melanoma, how far it goes into the skin. You're looking for the presence or absence of ulceration, mitoses, perineural invasion, and lymphovascular invasion, because those are 4 things that would make your melanoma more aggressive. You're looking for a histotype, which is superficial spreading, nodular, lentigo maligna, because that also brings a certain small bit of change in your prognosis as well. You obviously want to look at margins, because margins are important. It helps, one, to tell you how your melanoma should be managed moving forward, because if you have a positive margin, a larger excision needs to be completed most times. If the deep margin is positive, especially, it's important because, you could have further melanoma underneath it. So looking at margins is extremely important. A lot of times on the pathology report, and this will usually be present in the gross description, that gross description will tell you how big the excision or biopsy actually is, and that helps us because it tells us how much of the skin was actually removed. So, you're looking at, and it'll tell you whether or not the nevus is excised in its entirety, which is also extremely helpful for clinicians to know what steps to take later. Make sense? So the only other thing that I do want to bring up, and sometimes this is present, sometimes it's not, especially in older pathology reports, patients that have melanomas that are in the deeper range where maybe in certain centers, molecular testing might be auto-ordered, which I will tell you does not happen very often. But sometimes molecular testing like BRAF will be automatically ordered, and that'll actually say it on the pathology report. The pathology report's sort of a record of what happens to this path specimen. So if they order molecular testing right off the bat, a lot of times on the path report it will say molecular analysis pending, or BRAF testing pending. So that kind of information will be on there as well. Miranda, with biopsies, what if you're allergic to lidocaine? So there are other types of numbing medications that you can use that are derivatives or similar to lidocaine but aren't lidocaine. There's actually also a clinical study that I won't bore you with, but that shows that you can actually numb the skin by just putting saline between the epidermis and the dermis. I wouldn't recommend that, because who knows if that actually is accurate across the board. But there are other alternatives. You just need to ask your doctor and make sure you tell them that you're allergic to lidocaine. It's okay. They'll find a different way to numb your skin. The other thing that I wanted to talk about before I forget is, when should you get a second opinion? This is a question that we get a lot. Most of the time, and I say most of the time because nothing is ever 100%, but most of the time, if a pathologist is calling something an invasive melanoma, it will be an invasive melanoma. It's very unusual for things like Breslow depth, ulceration, things like that, to change from pathology department to pathology department. So if you have a, path report that says you have a 1.8 millimeter non-ulcerated melanoma, that's probably pretty accurate. The cases where a second opinion would probably be helpful would be in cases where you have a melanoma in situ, or if there's a pathology report that says a severely dysplastic nevus that is bordering on melanoma in situ. So something that might possibly not be malignant, or a severely dysplastic nevus that maybe has a lot of atypical findings in the microscopic description, which your doctor should look at. That would be a reason to get a second opinion if you're really trying to decide between a malignant versus a atypical but still benign process. or if you're trying to decide pathologically between a Spitz nevus and a Spitz melanoma. There are some specialized tests that have to be done on that pathology report to really distinguish it from one another. And that's also a very difficult and technically difficult pathology to read initially. So that would be a reason to get a second opinion. Another reason to possibly get a second opinion would be if somewhere in the pathology report, and again, it's usually on the diagnosis, if it is metastasis versus primary melanoma. A lot of times, and it's very clear cut. And one of the reasons why is that if there's a junctional component in the pathology, that means that the melanoma actually came from that area. Or was derived from the skin in that area, because that's where the melanocytes live, between the epidermis, which is the part of your skin you can see, and the dermis, which is the fleshy part of your skin. So if it has a junctional component, more than likely it's a primary. Metastases, by and large, lack that junctional component, and because they got there from somewhere else, so they didn't grow from the part of the skin that they're supposed to. So those are, in my opinion, 3 very good reasons to get a second opinion. Okay, I just wanted to look at this because there was something that I do want to talk to you. So Amy, you say something about a level 4 melanoma. So what that refers to is actually something called a Clark's level. It's a description that was very common to see on pathology reports, and sometimes is still seen on pathology reports today, to try to describe how far the melanoma goes down into the skin. The problem with using Clark's level to do this is that everyone's skin is a little bit different in size. So what a Clark's level 3 for me may not be a Clark's level 3 for someone else. It's not exactly accurate. So that's why Breslow depth has really become way more important than Clark's level. They still sometimes include it as a descriptive term, but it's not always reported. The protocol for so when you say T1A, I'm assuming that the 7 millimeter would actually be less, which I think we probably could talk about this offline. So if you want to call the 188 number, or you can actually fill out the form on AIM at Melanoma's website. We can actually talk about that online. But by and large, stage 1As are just re-excised. And depending how deep they are, close to a millimeter, they'll sometimes do a sentinel node. And also if they have different prognostic things like ulceration, stuff like that, mitoses, your physician may decide to do a test on the lymph nodes. But again, that's something that we can specifically talk about if you contact me offline. But I'm glad that you brought up the Clark's level, because that's something that I did want to discuss. Again, Erica, I can't answer questions like that live, so I hope that you'll contact me offline as well. Donna, what is considered to be a high mitotic rate? Actually, there are some pathologists that will only report it if it's greater than 1. We've seen mitoses that are, 13, 25. I think the highest one I've ever seen is 50. That doesn't mean that is the highest one. But a lot of times is if you have more than 1 per millimeter squared, which is extremely small, that will be reported as positive for mitoses. So I hope that answers your question, Donna, about what a high mitotic rate is. Amber, it's good to see you. Let me just look through some of these other things. Yeah, I think that's it. Do you guys have any other additional questions? One thing that I did want to bring up and hope that all the folks that watch these Facebook Lives can help me with is I'm looking to talk about women in melanoma. And so I'm looking for some ideas about some things you might want to hear about specific to women. So men and women, by and large, diagnostically are about the same. They're treated the same in a melanoma world. But if there are specific topics that maybe we could talk about specific to women and also to men, I would really love to have you put some of those comments or suggestions in the comment section. I'd really like to try to see if we can kind of target you and make you feel special and talk about things that are pertinent to both men and women. So let's hear your ideas. And then one more thing, Trisha, is regression a good thing to see or not? That's a very good question. Regression means that your melanoma has a little bit bigger depth. So when you think of it overall, regression has a poorer prognostic finding. It does mean that your immune system is engaging your melanoma, which is not a terrible thing. But overall, what it represents is that your melanoma is actually deeper than what is represented in the pathology report. So overall, probably regression would be considered a poor prognosis factor. I think that's all I have to talk about tonight. I hope that you guys enjoyed learning a little bit about your pathology report. Again, I'm always available to answer any questions that you might have in interpreting your path reports. Offline, you can reach me through filling out the form on the AIM at Melanoma website or at my toll-free number. I hope to see you guys soon. We'll see you next month. Bye now.